right, thank you. If I can have my slides up. So, Tomas, we're supposed to have a debate here, so there it is. So I took some liberties, and then I decided, you know, I've known Tomas now for 25, 26 years, and he's been a mentor to me. So you'll see there's a joke in here, but it's beyond a real debate. It's really just trying to look at other things. And you have to understand, I drank the Kool-Aid with Tomas years ago about atherectomy, so I'm really taking the provocative edge of alternative devices, not just atherectomy. And so hopefully this will be a useful process. These are all my disclosures. This is actually germane because I've served as a PI or as a leader in several of these trials. So to this point, I've had a long-standing friendship with Dr. Zeller. He taught me Jetstream back in the day, in the early 2000s, and I cannot in good conscience attack either his character or his friendship in this debate. But actually for this, what is listed to the left is going to be on hold for at least the short term. Not really. I can't do that. So Tom just did a great job of looking at why we need atherectomy. We've learned for years now that the SFA is an inhospitable location to work. Calcium and other things which tend to eliminate the benefit of either scaffolds or drug-coated balloons are the challenge. And so we have to change arterial compliance. It's not a debate that that's necessary. The question is, can we do it in a safe and effective way? And so for this talk, I'm really taking the provocative approach that I can use alternative devices, and I'll try to show you data as to why. Fabrizio really showed some fantastic data that calcium in this day and age of DCBs is an impediment to delivery of drug. And so by definition, we have to get through the barrier to deliver the drug where it needs to be. This is the primary effectiveness on primary patency for the reality trial. This was, as Tom just showed you, a 19-centimeter lesion, heavily calcified PAX 4 lesion groups. CTOs were 22 centimeters, and so to come out with directional atherectomy and a DCB and a primary patency in the mid-70s, I think is a remarkable testimony that, yes, we do need to do what we need to do. What's the challenge with this? Well, the challenge is that you pay an upfront price. And so the upfront price on all of these things, particularly with atherectomy devices, is going to be provisional stent use, low, but dissection rate and distal embolization adjudicated by a CEC and by core lab could be relatively high. So this is why distal protection becomes important. And you have to understand that going in. So that's point number one. What about the JET registry? Bill Gray and I were one of the leaders in this, and the lesion lengths here were about 16 centimeters. If you look at freedom from TLR and TVR, 12 months, remarkably good, despite a 38% crossover rate of stents. So if you didn't achieve the 30% or 50% endpoint and you stented, the stenting group with atherectomy did just as well as if you just did atherectomy alone plus plain old balloon angioplasty. This didn't have a lot of DCBs at the time. Now, what was the cost of this? In this trial, if you look in the middle here, they had several events, but the event rates were not 14%. In the JET registry, it was about 2% or less, but you still had embolic debris that are generated. Remember, this gives you an effluent, and then it aspirates. And Dr. Koum and I were just talking about how much you actually aspirate, and I think this is a really important part of how this device works. The other big device that's out there to change arterial compliance is orbital atherectomy, and probably the best trial was Liberty. I give them full marks for giving us data on claudicants, critical limb, and then even separating out the Rutherford sixes. And most of it was done with just plain old balloon angioplasty, and this was a registry from orbital atherectomy, so the majority of atherectomy was orbital in this trial. But if you look at the risks, and you got to look at the fine point here, but the angiographic complications, they say no severe angiographic complications. Not how many emboli they had, not how many dissections they had, but how many had little to no complications angiographically. 87-point-some% did very well, and this is in the Rutherford 6 group. But that tells you 12% had some form of angiographic complication. They don't denote what it is, but it's an important point. So up to 12, over at least 1 in 10, had a complication using orbital atherectomy in the worst of the worst, which cannot tolerate some form of angiogastric complication, whether that's dissection or otherwise. So what about the newer devices? Well, here's, as you probably have seen this, a very old slide, but Shockwave has now come along as a newer device, and it gives you this kind of wavelet of 50 pounds per square inch, being able to penetrate into this proximal area of the intima to crack intimal and medial calcification to allow delivery of drug. Let's see if I can move this forward. This is the PAD-3 trial. It was a randomized trial, 150 some odd patients in both groups, randomized either Shockwave versus DCB versus PTA DCB alone. When you look at the primary endpoints at 1 and 2 years, you see the separation comes early, and then there's a soft landing for the next year, but there's still a decline as people go through the next window. But that difference is continued and actually grows a little bit. When you look at the overall outcomes, they're very much weighted on the idea of arterial compliance to delivery of drug. That's what this is trying to prove to us. But when you have to get into the manuscript, you have to actually read where the complications are. And when you look at this, there were 2 clinical events, all driven on the PTA arm, not on the IVL arm. And that's an important subset. So it's in situ arterial compliance without having to disrupt the calcium, which becomes important. And so the effective rate of complications is low. This is from my old colleague Pete Tsoukas down in Merriam. This is his fellow Mohammed Baig. And this was in the common femoral. And what they showed, again, single center, small study. Please don't take this as gospel because the science behind it sometimes is always challenging for single center data. But the primary event rates of complications were 3%, 1 event, in the small group on the IVL and not on the directional atherectomy arm. So in this group, it was a little bit opposite of what I just told you for the overall thing. So for this debate, the question is, who wins? Well, I think long calcified lesions are exceedingly difficult for endovascular treatments. I think we need to change vessel compliance through either atherectomy or lithoplasty, and they both have shown efficacy and safety. I think each device has pros and cons. Lithoplasty has demonstrated improved vessel compliance in a simple to use, fairly facile for all of us plumbers in a PTA format that works. The complication rate and need for distal embolic protection are really muted with IVL. I think a 0 to 1% compared with up to over 12 or 13% with other atherectomy devices. It's kind of a win for intravascular lithoplasty. The questions are, do all therapies mitigate that risk? And in all cases, that's really where science meets reality. And the costs and outcomes favor IVL, at least on baseline values. And what is important with IVL is, and with atherectomy, in my opinion, notwithstanding this debate, is that they're all complementary. I think going into a case, one must consider what the outcomes are, how much you want to distally protect, and whether or not you need rotational, orbital, directional, or atheroablative technologies as a better therapy in your therapy that you want to choose per patient. It's not per science, but per patient. So thank you for your attention.